Very good afternoon to you all, and I see the hall is almost full. For my curiosity, I just wanted to know how many of us here we do laser photocoagulation very routinely. Can you just kindly pick up your hands? Oh, that's great. Almost at about 50%. The previous one, Dr. Shathi's talk was a lot of gray areas, a lot of controversies was there, but I believe that there is no controversy that we should do laser treatment for diabetic retinopathy. And because Dr. Satish has also told about that will be the gold standard of the treatment. I don't have any financial interest. To start with, this is again drcr.net, and they have a study which shows a 2-year period of time focal and grid photocoagulation is more effective and has fewer side effects than 1 milligram or 4 milligram of preservative-free triamcinolone. And focal or grid currently should be the benchmark against all other comparative trials. So this is in 2008 has been, and 3 years study is also result is also corresponding to the same. Now, the indication, before going to indication, you should have a very thorough examination of the patient, complete retinal checkup, visual acuity, all those, and slit lamp examination, particularly for iris and pupillary margin, and gonioscopy to look for neovascularization. Now, the indication is a big list of high-risk criteria. You can have NVD along with or without vitreous hemorrhage, NVE with or without vitreous hemorrhage, according to diabetic retinopathy study. But to keep it simple, if you have vitreous hemorrhage, if you have subhyaloid hemorrhage, if you have neovascularization of the disc, neovascularization elsewhere, neovascularization of the angle or iris, or if you have CSME, these are the gross indication for doing photocoagulation in diabetic retinopathy. Now, what you need to know is, obviously, like just previously was getting discussed, is systemic status. That is one of the most important part. I think Dr. Saurabh will be talking about it. And the condition of other eyes also. The eye which you are treating now, the condition of other eye is also of utmost important for the treatment. And whether the patient's ability to follow you up very regularly, that also have an implication on your treatment protocol. Now, just to explain patient first, this is not an injection, this is not a surgery, and this will be done at the outdoor process only, and in a sitting position, you need to tell them that near about 10 to 15 minutes it is going to take, and there may be a slight amount of the pain, so that patient should be mentally prepared and will be more cooperative to you. Patient's physical condition assessment is also one of the important factors, whether the patient is having any neck deformity, whether he will be able to put chin or not. IQ level of the patient do affect sometimes, and the comfort level of the patient, and that is one of the most important factor before starting laser photocoagulation. So you can just adjust the stool height, properly place chin rest, and forehead placement properly. Put local anesthetized, place the lens and wait for some time so that the patient can get acclimatized with that system. You can increase your slit lamp illumination slowly so that the patient can tolerate up to that level, and aiming beam intensity should be low, and then you can adjust accordingly. This is like an ideal situation how we can put it off. Lenses, again, it depends upon like which lens you are comfortable with. For doing panretinal photocoagulation, again you need to have a wide field lens. Mainster standard is quite okay for everybody, but I personally prefer this Vogue SuperQuad 160, which give you almost 160 degree view, so that in one shot you can go to the periphery and finish it off as much as possible. Magnification factor also you need to take care of into consideration, and macular laser I prefer either of Minster or area centralis. This is a big list of how much magnification and field of view will be there. So you choose your lens accordingly and just be with that. So to start with, spot size usually around 300 to 500. 300 is quite okay. 500, if you are able to put buns, is absolutely fine. Duration is around 100 to 200 milliseconds. Power, again, it is, you need to slowly adjust it off. The duration of the cable fiber what you are using depends upon a lot of factors, depends upon that. If it is an older fiber, then you need to increase a little bit off, and slowly you can adjust it off. Presence of cataract obviously affects your amount of power to be used. This is an IDRX machine. It should be done in 3 sittings, near about 1500 to 2000 burn total, and 1 burn width apart from each other. Start in an arcuate fashion about 2 disc diameter from the disc, and inferior nasally, to start with inferiorly nasally, then superior, and last to the temporal part, and treat at least up to equator. This is a proliferative diabetic retinopathy with high risk criteria and has been treated successfully. This is, again, I just wanted to show, this is a very close to optic disc, so you need to avoid that and put it little, at least of 1.5 to 2 disc diameter away from the disc. This is a macular photocoagulation done. This is just before and after, immediately, the other eye of the patient. This is photocoagulation done, and 3 months later the hard exudate and the CSME, what is there, has been regressed completely. If macular edema is present, then treat concurrently and do the temporal part at least near about 3 to 4 weeks later. Aim for light to medium burn or just to tickle the RP, and there should not be any bright burn in case of macular edema. Focal grid or modified grid is the option. Conventionally, it is being done C-shaped away from the temporal. These are the do's, and the don'ts are, do not treat NVD, obviously. NVE in the parafoveal region, elevated NVE, and preretinal heme. Preretinal heme you don't need to treat. Elevated NVE can cause bleeding. Stay away at least 2 disc diameter from whenever there is a focal traction or proliferation is there, and the area of long ciliary nerves to avoid pain. And in case of burnt out retinopathy, you don't need to treat, because what you are going to achieve has already been achieved by burnt out retinopathy. The disc is pale, the peripheral retina has already been died out, so you don't need to treat them. Supplemental treatment is again a controversy, whether you need to treat them or you need to give anti-VEGF or treat them. Near about 20% or 21% of the patient, they have complete regression according to DRS. But the new indication is that when you have development of new NVD, recurrent vitreous hemorrhage, new development of rubiosis, then you can treat them, or there is scanty treatment, incomplete treatment, or there is a large area of skip areas, you can treat them. Near about 1,000 burns you can put, and indirect laser is one of the good option for this. The main side effect is mainly the difficulty in near vision and a minimum amount of the exudative body. These are the most common. Whereas contraction of the posterior hyaloid face can cause a recurrent vitreous hemorrhage in this kind of post laser. Worsening of macular edema is one of the dreaded factor, and some amount of the psychophysical function, lowering of dark adaptation, visual field loss. These are one important side effect. And to summarize is to examine carefully and explain in detail, go slow very carefully, check fovea each and every time whenever you are putting your laser burn, and be sure about your complication, follow them up very regularly and retreat them whenever you want. This is a small animation, how diabetic retinopathy can affect your vision and how is laser is being done. This is just to show it was actually being made for an awareness program, and some amount of the hemorrhage is noted in the posterior pole. These are the hard exudates, and you can have some patches development over there. So you can keep on doing laser. Thank you.